I've had the privilege to know these people a long time. So why don't we just kick it off? Why don't we start down here with Mila? Can you introduce yourself in a minute?
Sure. Good afternoon, everyone. I'm happy to be here. My name is Mila. I'm leading AI governance. Unfortunately, doing the stupid things that we heard about previously, but we're going to discuss about how we actually do AI governance in Atlantic Health. So Atlantic Health is one of New Jersey's largest healthcare systems. We are spanning 7 hospitals, about 400 private care clinics, and about 1,000 providers. As I mentioned, I'm doing AI governance. I'm leading this effort enterprise level. My background is data science, data analytics. I've worked in a couple of medical AI startups. So on the vendor side, developing those solutions, implementing them in healthcare systems, and previously worked in a large hospital around clinical innovation and data science and analytics. And happy to be here.
And I'll just share for a second, Atlantic has some rather prestigious alumni in the healthcare world. I believe Secretary David Shulkin was a leader of that system for a while. He went on to be VA secretary across, basically part of the VA leadership across 2 administrations, and survived Trumpland for longer than your average rodeo rider, for sure, and is a good friend of mine. And then Amy Perry, who was COO very recently, has gone on to be the CEO of Banner Health System, which is one of the most thoughtful health systems in the country, in my opinion, and a good friend. Okay, Rob.
Good afternoon, Rob Bart. I'm the Chief Medical Information Officer at UPMC. Pennsylvania, predominantly, a little bit in New York, Western New York, a little bit in Western Maryland, but 90% in Pennsylvania. 40 plus hospitals, 800 ambulatory sites, plus a health plan. I'm also a pediatric intensivist. So I've got good clinical partners. They let me work about 1 quarter in the ICU. Keeps me busy, and I'm going to be for quite a while. So I'm looking forward to the conversation.
Yeah, and by the way, we met at one of these type events out in Idaho 10 years ago. So, and we've just been real friends ever since. And so I think it's an ode that these events are not only just a place to do some nice networking and maybe get a deal done, but you actually develop real friendships. And we met, I can't remember.
I really can't remember.
Yeah, it was yeah. But I'm always trying to drag Mila, and I'm always disrupting her family operations by convincing her to abandon her 2 small children and have fun with me in New York. But that's another topic. Christian.
Hi, everyone. Krishnan Narasimhan. I'm the family medicine physician. I'm the chair of the Department of Family Medicine at Stanford Health. It's a large health system in southwestern Connecticut, outside of Metro New York. We have about 18 sites, several hundred people across those locations. Also oversee all the residency programs as the DIO for the institution. Done a lot over the years. I've been involved in health policy, actually lead some state level health policy around physician workforce right now. On the tech front, I direct an AI innovation lab in our department, and rightly or wrongly was involved in setting up some of our core AI governance, so we'll find out. I know Neil because we survived and did a VBC based startup several years ago, which if we'd been able to do everything, would have changed the world. But here we are.
Yeah, it was interesting. It's also a good sign that even if your startup fails, sometimes you get good friends out of the deal. We also lived. It's interesting. A lot of you probably who are in the startup life are worried about getting funding. We had things sort of pretty well set up. Then the government decided to pause the program that we had wrapped our whole strategy around. And pretty soon the party went from being pretty full to pretty empty. And the whole thing fell apart. So it was interesting. It was just a good example of how you can line up all the bowling pins in your lane. But, we're in a big world and someone can come and stomp on it in 2 seconds and you're done. Okay. Speaking of a big world, Mila, you're off in the front door for people in this room coming to talk to Atlantic, people at Atlantic coming to you. So tell us, what are people knocking your doors about now and recently? And how do you think about dealing with it on a day-to-day basis?
Yes, so obviously there is a lot of knocking on door happening right now. As was mentioned previously, it's really accelerating, and What I want to say about AI governance that it's not necessarily stopping things or, obviously technology is moving fast exponentially every day and every hour we have technological advancements. So it's really about how do we leverage the technology? How do we identify what are the problems we're solving with this technology? How do we measure the impact of this technology? A lot of times those things are not necessarily correlated or naturally aligned, and it takes us time to figure out what is actually we are looking to solve with the solution. So I would say that I have a lot of knocking on my door, both from the vendors and from our internal teams. And I can bucket this into two main buckets, which is people really know what they're trying to solve and they're saying, okay, I want this solution because I think this solution is going to solve my problem. And I would say the majority of times I actually get conversations around, we want to implement this technology. And the way that I start, peeling this onion is, okay, why this technology? What are you looking to solve? How do you know that there is a problem on the enterprise level, right? We have so many service lines, hospitals, there is big variation between different workflows. How do you know that this is the problem you're looking to solve? And how do you think that this technology is going to solve the problem? A lot of times that enforces conversations that, get the person to go and do some homework, to get some data. And this is where the governance comes into place to ask those questions and walk them through a framework of, getting this information upfront so we don't get into a position where we implement technology and only then we start thinking, okay, did we actually achieve a value? Because it's very easy to, well, it's not easy, but you can implement the technology, but then it's very hard to go back and understand how it actually influenced something. We also have a tendency to measure what is available and easy to measure, right? So, we can measure things like engagement and operational things, but how do we know that it's actually influencing the needle that we want to move? So these kind of conversations are happening on my desk.
So I ask a couple questions and then I'm terrible. I ask a gazillion follow-up questions and we never get off the first question sometime. But let me go, I got to dive in because I think that circle back and measurement piece is a big deal, right? Because you do want to show activity, right? Like we're so good in healthcare, like stuff's going on, right? How are you going about in a complicated world, making sure it ties back to like a solid business case? You know what I mean? Where like, we have core financial issues and operational issues. How are you seeing that link through?
Well, the way that we work with the business, let's say our business stakeholders, we're building some kind of a timeline to understand how things are actually happening in the workflow and understand what is correlated with what. So let's say we're implementing AI agent that is doing care coordination. We want to understand who is interacting, who's the end user, what kind of operational KPIs we can put together to measure this engagement, and then how different engagement types are influencing the end outcome. Is it clinical? Is it operational? Is it financial? Right? And then we specify all of that. We build some form of a timeline, and then we start putting the measurements around each one of those steps.
Got it. So you've got a rather large enterprise and things, sometimes you're the front door, but sometimes you're the last door or the second to last door. And so I want you to talk about all the other things you've got going on, the cool and not cool stuff at UPMC right now, right? And then how are you adjudicating, prioritizing things?
So what I would put in the not cool would be, we're doing a large Epic EHR project right now. And that's just fundamental foundational, UPMC. Go ahead.
Can you just articulate what does a large thing mean? Sorry.
So our small go live, which was in September of last year, was the largest single go live that Epic's ever had. Our larger go live is going to be in May. So we've got about 100,000 employees at UPMC and about 85,000 people are being trained. So it's a pretty large enterprise. If you've heard about UPMC, you probably know that we've grown through acquisition. That acquisition meant that we had 9 different EHRs. And I think with the advent of moving into a world where you want to enable artificial intelligence or intelligence into your EHR, trying to do that 9 different times is really unappetizing. And so it became really a non-decision to move to a single new platform to be able to deploy tools equally across our geography. So that's, I would call that just fundamental basic work. It's not, there is fun, but it's not necessarily what drives what we want to do. I think what I'm interested in and what we're looking at is the opportunities to deploy intelligence across the healthcare system, whether it's in the front end where the clinicians are or in the back end in revenue cycle. I think the thing that I'm most interested in right now are those things that end up impacting operational efficiency. Being a clinician, I do think there's benefit for artificial intelligence in the clinical diagnostic world, but I actually think for the most part, clinicians are actually pretty darn good at what they do. And I don't think AI is right at that point in many instances where it can actually add benefit. And right now, if you insert AI in the clinical domain without gaining efficiency, you've added operational costs, and CMS has not changed how they reimburse, right?
Yep.
So I'm more interested in artificial intelligence that really focuses on the operational improvements of efficiency. You know, the multidimensional math of how do you get as many patients into 15 OR suites in a given time span as possible, right? Healthcare systems have struggled with that math for 50 years.
Yep.
And I think AI is starting to help us unlock for some of those opportunities. Or, you know, the back end coding opportunities, a lot of opportunities in those spaces. So I think really it's about creating a new framework with our single EHR instance, then allowing us to enable sort of leveraging intelligence.
One question to the crowd and then one question to you. To the question of the crowd, just on your point about operational efficiency, have people seen this crazy chart that's out there that shows the number of doctors versus the number of administrators over like 40, 50 years? Show of hands if you've seen that chart. Okay, I wish I had it up here. Should have brought show and tell, wasn't prepared. But if you want to understand part of the cost problem in healthcare, you realize that we have like, you know, 100%, I'm going to ballpark some numbers. So any CFOs in the room, apologize in advance. We've grown our doctors like 100% over like 30 years, 40 years, and administrative support staff, fillers, coders, front desk staff, like 1,000%, right? And so that's really what you're talking about, is that 1,000%, right? And I actually want to just dive into the Epic question for a second. We weren't prepared for this, but I just want to dive in. So you now are going to be one of Epic's biggest customers, right? How are you thinking about, or how have you wrestled with taking the lead on doing stuff versus collaborating with Epic, you know, so that, you know, you're driving the strategy, Epic's not driving the strategy, given that you're on one boat now?
We've already started sort of doing some of that. I mean, we're having advanced discussions with them on different tools for artificial intelligence that they haven't thought of, that maybe others in the industry haven't thought of. I'm very interested in the paradigm of scheduling and schedules for different clinicians. I've been working with our orthopedic surgeons, for example. Orthopedic surgeons, they want to keep their clinic schedule filled, but the truth of the matter is, it's number of people they see in the office that convert to procedures in the OR that actually end up balancing their pay, right? And so how do you predict which patients have the highest likelihood of potentially becoming follow-on RVUs, and then load balance that across your orthopedic surgeons? Because it turns out that there are some schedulers who are really good at fishing based on the chief complaint at getting sort of a high follow-through, and others that aren't, and that creates this imbalance in the work. And so that's an area where I've been spending a lot of attention and trying to think of how can we actually use intelligence to help solve that, so that everybody gets an equal opportunity. But most importantly, it translates into patients getting seen and getting treatment sooner in a much more effective manner. So, those are
really using AI, if I can paraphrase, really using AI as the air traffic controller.
It is.
Yeah, which is true in other industries and less true in healthcare.
True.
Have you been to do people still do this anymore? I've been to manually nurse staffing meetings where people are like arguing over schedules. Anyone still have that stuff? Stuff still goes on in your hospital?
Goes on in most.
Unbelievable. Unbelievable. Okay, Christian, can you talk, you're a frontline physician, right? You're seeing patients Oops. Most of the time we got tech support. Hang on here. You're seeing patients most of the time.
Makeup good.
We're talking about a lot of different tech. Can you talk about the stuff you're seeing, right? Because Rob already made the point, like doctors are pretty good at what they're doing, right? Like you trained a long freaking time to learn how to do what you do well, right? And you stay inside your scope. So how is this tech helping you? Does this tech end up helping you? And what is like noise to you? Like, oh, that's interesting, that's cute, that's fun, but I'm not sure it's really going to change the life of me or my patients.
Yeah, no, great question, Neil. So sort of on the front lines, I think we're seeing a lot of different things, and there's always right now there's a lot of hype, there's a lot of excitement, but how much that is going to translate into things that really help? And I would say just like what's going on in geopolitics, we're being buffeted by lots of forces, right? Two big things that we've seen is number one is access to care, right? We have too much demand and too little supply, despite some corrections after COVID, that still exists. Good luck trying to get a primary care doctor, right? If you're anywhere in healthcare, somebody's probably hit you up already, but do you know a doctor? Are they taking new patients, right? The wait times are huge. So that's there sitting on top of things, right? That's both a challenge and an opportunity. Then the other piece I would say is access to information, right? So if you ask me what's the most successful deployment of AI over, let's say, 2025, I'd have to say open evidence. I mean, my gosh, that really flew out the gates. I was shocked. I remember it was a board meeting where they were having a couple doctors present, and it was really early on that open evidence came on the scene. And the doctor comes on. It's supposed to be a very formal presentation. Oh yeah, and I loaded all this stuff into open evidence, and here's what I'm going to do with all that. I was like, well, it's done, right? So despite all our carefully crafted, thoughtful compliance strategies, these explosions, I think, are happening. So, but how do you harness that? How do you use that at the point of care? So we've got an innovation lab. So we're really trying to think about how do we imagine a bit of a future state? Because I think implementation is still very difficult. And to your point, how do you get it where it's not just another inefficiency, right? You've got agent layered on top. You've got another screen to look at. You got to click that, right? I mean, we've done this many times in healthcare, right? Where we layer inefficiency on inefficiency. You talked about the administrator, which is people, but we layer infrastructure on top of infrastructure. And that leads to this huge administrative burden that we're trying to tackle. So I think we're still a little bit early in getting tools at the point of care that are going to make a difference. I mean, there are some examples like ambient, which I think is closer to sort of ready for prime time. It's being deployed already, but others are going to take a little bit longer.
So I want to talk about open evidence for a second, because you mentioned it as something doctors are gravitating towards. What percentage of doctors are opening open evidence, and why do you think they're gravitating towards
all of them, practically, right?
Okay.
And that's what struck me. It's interesting, right? Because we've set up, we've got careful vetting of tools and vendors and all that, and then there's these external forces that people are adopting, and it's on their own phone, and so I've had actually very interesting conversations. So we did a study in our innovation lab. We were looking at our residents and attitudes and beliefs around AI. It's actually very positive. Now, they're a younger generation, digital natives, but I was surprised by how positive it is. They've got some concerns, but they really feel they can harness it. I also had an interesting chance. We talked to all our employees with kind of a, hey, get to know AI kind of thing. Everybody knows how to use it on their phone, right? And people are quite comfortable, way ahead of whatever structures we're trying to set up. So I think that's the environment where the general public, our employees, or some of our colleagues are ahead of where we are, and we're playing some real catch up here.
I'm kind of curious. Let me just bounce this to the audience for a second, just in case one of you, has anyone here been at a system or a provider that's actually, like, in any kind of semi-science way, like actually measured patients' attitudes on this topic? I'm kind of curious if we actually pulled back the onion, what that'd be and what that would be across demographics, by the way.
You know, the team this morning from Mount Sinai did mention that they were running focus groups.
Yeah.
They have data. So it'd be good to talk to, I can't remember, who mentioned it.
Oh.
Sorry.
I know, Lisa, you stayed the whole time. You've been like on us. I'm waiting for your hard question, by the way, Lisa.
No, I need more coffee, I think.
Yeah.
Yeah, we have done a series of focus groups. We and informally talk to patients as well. I don't know if we've summarized the data in a way that that's why I was hesitant.
To put
But
your
I
hand up.
do believe others out there may have done it as well. I think it's a critically important step that we understand beyond anecdote. I can tell you what we hear from patients is they're thrilled that their doctor is again looking at them and making eye contact without being distracted by hands on keyboards, eyes on screens. But collating that and summarizing it in a scientific way, I think is key.
And I also don't know if I can just for a second, and we'll see what happens with the data. And I'd love to see this stuff when it comes out. And honestly, it should that should be in like New England Journal of Medicine, because if we don't, you know what I mean? Like we publish lots of stuff, but we don't know how. I have the feeling that we're gonna, when we peel the onion back, my hypothesis going in would be that we may see some very different things depending on the demographics of who it is, and less about age actually than education perhaps. And so that might be a useful insight as we try to figure out how to navigate this and who's excited and who's concerned and scared, frankly,
Right.
about this stuff. I'm actually going to steal a question from Shahid earlier today, which was just too good. Because we've been talking about making decisions about stuff, but what he said earlier was like, okay, what do you feel like, sort of fill in the blank for those of you around this morning? Like, I want to just ask each of the people on the panel, what do you feel like people should stop calling you about? There's a bunch of partners and vendors out here, and, New York has 1,000 of them, right? And what should they be calling you about? In other words, what have you already kind of solved? Or you're like, listen, we've done our homework on this. We don't need the 15th company talking to us about the same thing. And what have you not seen, at least with a company that doesn't feel like it's being built out of somebody's basement? Who wants to start?
Sure, I'll go.
Sure.
I'd say the first thing it'd be ideal if you don't come to us with a fragmented care option, because that's the other big thing that's going on, right? Care is getting chopped up, despite all these tools and things we talk about, care coordination and connectivity, we're behind, right? In 2026, it's surprising how much it's that. So coming with, I have this super narrow thing that solves this tiny thing is a challenge. The other thing, look, I know a lot of companies want to move fast, but just coming to us so that you can do a small trial with us, right? Proof of concept, all that, that's not all that useful. It doesn't always translate much to what we want to do. I think we're looking for relationships, not to sound old fashioned, but that's actually what would be useful, because we can all say that no matter what the fanciest things we put in, the implementation's not. And it goes on for a long period of time. We did our Epic go live a year ago. I mean, it's still with us, right?
It's like you've got some like PTSD shakes there. And you're
A little bit. But yeah, so I think you want a partner that you can work with. So that's it's important to build that relationship, to be able to come back, even after you sell somebody a product, to be there to help them with the implementation, I think is real critical.
And can I key on that just for a second? Because I think that's a really important point that when I work with companies, I try to emphasize, and I just had this conversation with Mount Sinai this morning as they were walking out the door. For those of you who are out there and you've nailed a use case, that's great. I would suggest, my 2 cents is, and I don't know how you feel about it, that's great you nailed one use case. Maybe you have to form a set of partnerships so that way you're not walking in the door trying to solve one problem, but at least you've got a series of them. The other point I'll say real quick, sorry, just to take moderator's prerogative, is part of the thing about a relationship is to make sure like somebody knows you're going to be around in a year, right? And so I think that's really important, and that's hard because startups often disappear, and you don't really want to be on the end of that.
Taking what Krishnan said, free pilots are not free. So
Exactly.
a free pilot from the vendor perspective can cost UPMC anywhere between $150,000 to $300,000. Time and materials, et cetera. Everything has to go through security review, architecture review. So I governance. I pretty much
Exactly.
stop the conversation if that's how someone tries to come in the door. So I don't think that's a good strategy. And plus, if me and my colleagues aren't smart enough to know whether we want to pilot something, because I don't believe in piloting. We need to know how to make the best decision for the organization and then figure out how to scale something. I think one of the challenges right now, and that's because a lot of the artificial intelligence that's coming out, especially in the agentic end of it, are very narrow point solutions. And I don't have enough people that can connect all these point solutions. And so unless something has a really, value of investment or return of investment opportunity, we're probably going to be late towards wanting to adopt it. We're looking more for those who are generating or creating a platform that would allow a number of point solutions to stand on. That's the only way we can scale effectively and efficiently at UPMC. Go ahead.
And how do you, just politically, I mean, I was in in a seat related to yours for a long time. How do you politically say no to all the docs who are super excited about their thing, which is honestly how a lot of pilots happen? Docs or different stakeholders are like,
So-
I got a thing. How do you like, no, because you want them, they matter to the team, but this is like, it's not a bone you can throw them. I mean,
Yeah,
I'll just level with everyone here. Yeah.
I mean, I actually say no a lot. I mean, a lot. If I didn't say no a lot, I probably wouldn't be employed.
Yeah.
First, but I think there's a way of handling it. You need to, they're all intelligent, and UPMC has a history of innovation, so it attracts a certain type of clinician who wants to be innovative. But it's about taking that and redirecting it in a manner that can be more structured by the healthcare system to
Yep.
leverage. Many years ago, it was just coming up. VR was sort of big, right ahead of the COVID-19 pandemic, and like every surgical subspecialty had a different company, and there was no way that we could launch, each surgical subspecialty a different VR company. In that instance, the pandemic actually made all of that noise go away, but it was trying to get the neurosurgeons and the ENT surgeons and get them in the same room to figure out what were the commonalities of what they were looking for, and then get them to start thinking about how can we have a single platform serve what you're doing, as opposed to me as the chair of neurosurgery and me as the chair of orthopedic surgery. So generally it's getting them to come together, have the right conversation,
Yep.
and also making sure they understand what problem they're trying to solve. A lot of people, to your comment earlier, they bring technology, but when you ask them, what is it you're trying to solve? They can't answer the question.
Yeah.
Right. And we all,
They can already give you improved patient care, and then, okay, what does it mean?
or patient safety, right? That some of the catchphrases. And I think that you need to really challenge them to go back and say, this is what I want to solve. Right. And I think that it creates a healthier dynamic.
So, which raises an interesting question. So, if you're not just saying no, but you're educating them along the way, which is what it really sounds like, how much of your day are you spending managing stakeholders and kind of educating them?
That's probably 50% of my day.
Okay. So, I think that's one really interesting difference, honestly, between your job and the equivalent of you sitting at GE American Express. Because the answer is kind of no and get out of my office in a nice way. Right. And so it puts a real tax on the system, but it also makes what you do like so much more important even.
Yeah.
Sorry.
I was just gonna say, you have to have some tact in doing this, because the next phone call, if you don't, is they call the CEO.
Yeah.
The CEO calls me
Yeah.
and says, I hear you weren't,
Yeah.
So I think, physicians are still relatively powerful within healthcare systems. And so you have to navigate that.
Half the meetings I took with vendors was somebody board member's cousin.
Families.
Yeah, exactly. Mila.
So I would take my answer to two directions. First is, well, obviously, I'm actually looking a little different approach.
Oh, good.
I'm struggling with solutions that are coming in to reimagine something. I think when you have a very wide scope, you're really not solving everything. And I've been to several conversations with vendor when I asked them, so what are you solving for? Are you saving time? Are you improving care? Are you creating a financial ROI? And guess what the answer was? Everything.
Yep.
And no. You need to solve something, but something good, you can't solve everything because things are not necessarily correlated. There are other factors that are affecting certain things, so it's very hard to come in and say we're solving for everything, or we are reimagining primary care, we're reimagining in-house operations. It's is actually when we have a specific use case, when we have a specific problem to solve, and then we tailor a solution to it. So that's one thing that I would definitely encourage vendors to think about: what is the problem they're solving and how they promote this use case within the healthcare system. And the second thing is that we're also Epic first, right? So leaning into the Epic roadmap, and they publish their roadmap through their channels, is also important to say, because a lot of the things that now we're talking about, and again, it's been said over and over, that technology is changing so fast, so rapidly, that we might be piloting solution that tomorrow new technology comes in, and then what do we do with that, right? So typically we are Epic first, and we're leaning into the Epic roadmap and working with them to develop the solutions, both from our end, proposing features and implementing their solutions. So it's really important to understand what is the signal from their side. We also have publications or other publicly available data in terms of what solutions we already have in place. So if we already have ambient scribe, or we already have voice agents for call center, we're not going to implement 2 or 3 of them. I actually was asked about this today. So, okay, you're piloting now voice agent for call center. Maybe you want to do a pilot with us and just compare them side by side, which is originally a great idea if we have limitless resources.
Yeah.
But we have only a limited set of resources, and we still haven't able to really fundamentally showcase value. Like, we have a lot of ideas, and this is where I'm coming in on an enterprise level to really help put together a set of tools and a set of processes where we can systematically measure it and really showcase, okay, so this technology really helped us, improve this KPI. It's also hard to do because sometimes it's hard to showcase how the technology piece actually helped the KPI. You might have improved the RVU because you just added more radiologists to the shift, right? You could have extended some other efficiency that are not even technological. How can you prove that the actual technology piece, that's the thing that contributed to the ROI? All of these challenges are present, and we're dealing with them on a daily basis. And when we're saying no, it's not because we want to say no. It's because either the use case is not clear, or we're not looking to solve this problem right now. We have a certain set of priorities that we want to solve, or we are looking at Epic to solve it in the upcoming future.
We're about to turn this over to audience questions, which is great. I just want to tell one quick story that ties the 2 of your points together, which is who here has heard of the Milken Institute and the Milken Forum events across the country, especially in California, the big hoo-ha event? So speaking of both frying a really big thing and trying to integrate lots of information, this is about 2 years ago, a tech guy, brought in lots of tech guys from Silicon Valley, largely guys, and said, hey, what's the real best future use case for the best AI? And in this room full of CEOs of companies all over the country, often public companies, this room is making like billions of dollars a year personally. This guy was like, yeah, if you think about the jobs to be done, the job that's most about integrating lots of data and making decisions is the CEO's job. And so that's the logical best use case for AI. And he said it with not a wink of irony, and the room just groaned rather loudly. So, okay, with that, audience questions. Yes, ma'am.
You mentioned Epic first. At what point do you evaluate a potential solution and say best in class versus Epic first?
That's a very good question. To me?
Yeah.
Okay. Because we all Epic.
You should answer.
So it really depends on the use case itself, right? There is big variation. Are we talking about operational, clinical use cases, primary care specialty? It really depends. But I would say in general lines, we are estimating what is the transferable capabilities of this feature if we have a feature in Epic that we can then transfer to other specialties. And if we are now implementing a siloed solution that is only solving for specific specialty, then how do we scale it to other specialties? Usually Epic is, offering us capabilities to then imitate this workflow to other specialties. So, additional scaling efforts are potentially, lower, right? So when we are looking at Epic versus vendor, this is also part of the consideration.
Okay.
We do the same valuation. I think I'm sure a lot of organizations leverage Epic through the same sort of thinking process. We do build some of our own AI agents. Based out of Pittsburgh, Carnegie Mellon University is there, and so there's a lot of access to people who are appropriately trained. I think when we look at things that need to be localized based on your data, like length of stay, risk of readmission, what's your surgical mortality risk, those types of stratifying calculators, we've tended to want to build them ourselves and test them and evaluate them on our own patient population, as opposed to taking someone else's agent and then having to, because you have to go through testing it anyways. And so how much time you actually save, you can argue. So we're fortunate enough that we do have some people in-house that are data scientists to help us work with building these. But I think some of the broader workflow engine type things, we're going to leave most of that to Epic.
Okay, I saw a bunch of more hands up. So over here. Yes, ma'am.
Hi, everybody. So great discussion. But I want to actually add on to that first question there. I think that y'all are right that there is a place for relying on the Epic roadmap, particularly in those clinical workflows and understanding that. But I would like us as an industry and as customers of Epic to coalesce more around putting pressure on them to be more open, to do more integrations with some of these innovative players in the space, to really lift that kind of like the moat around there, for us to move faster and get to what I consider consumer grade applications for our patients and our clinicians. But I think, thank you, but I think we need to, as the customers, echo that loud and clear to the folks in Verona that we cannot wait for them to develop in their tool set.
So hang on, let's get the audience, let's get the panelist reaction to that. Do you have any quick reaction to that?
I do. I think it ties into a bigger thing. And if you look across society, right, institutions are being challenged. So why should we be any different? And why should be the largest player in the HR space be any different, right? There's a veil there, right? Of course, and control, but how long does that last? And what's interesting, conversations from earlier today, if someone is coding their own AI agent to do a specific task and that is replicated 1,000 times over, right? Now there's competition. So I do think it behooves, whoever the largest players are to open up a little bit more, to integrate more, to collaborate more, because things are moving fast.
I think you have a very, very good question. There's no question that Judy wants to own innovation in healthcare, period. I mean, there's no question. If you look at EHR vendors over the last 30 years, we've gone from nearly 1,000 to about 30. And that consolidation has ultimately led to less and less innovation. The other thing that actually facilitated some of this lack of innovation was also meaningful use. Because if you look at when meaningful use came in, the largest number of EHR vendors actually stopped because they didn't want to comply. So the combination of those things and the fact that although Epic doesn't legally qualify as a monopoly, they are nearly a monopoly right now. I think that I personally have big concerns about innovation in healthcare from a technology perspective because of how much of the market they control and the direction. So there is this tug of war, right? We, as Mila said, we want to partner with them to get more from them, but at the same time, we want to challenge them and do some things independently, and they can actually make it pretty hard for us, as you all know.
Yeah, and just to take on that, how much is Judy worth nowadays? Like personally?
I don't know.
She's a legit billionaire, by the way.
Oh yeah, multiple.
Yeah, and so, you know, I was joking with her. I've only met her once. I was joking with her about another billionaire, and she was like, "Those are my people." Okay. So just that's kind of where she's coming from. Back.
Hi, I love your question that you posed and I love all the comments. So I have a background in biotech and cancer research drug administration and the approval process for that. So a biotech company can easily spend $200 million on a clinical trial just to get it FDA approved. And that's only one component, one small element of a 15, 20-year timeline of what it takes from discovery to approval. And then once you get to approval, how do you optimally deliver that therapeutic and continuously improve upon that, whatever treatment therapeutic that is. Epic has been a huge problem for the biotech industry. It's a huge problem for biotech, for the healthcare ecosystem. I think it is our responsibility for every one of us in this room to put our heads together and figure out how do you help Epic be more cooperative. Because if we think about ourselves as a society, as species, it's not survival of the fittest if she's thinking about Epic. It's survival of most cooperative. So if we think about our healthcare ecosystem, we will be outnumbered and outpaced by other people who are not Epic, who are going to be more collaborative. So I really like this discussion. And I really think that the biotech sector, the private sector, the pharma sector would really love to help hospital systems figure out how to do that. Waiting for an Epic build to get a clinical trial through takes at least 6 months. So we feel your pain. We know patients are waiting, and we know that in cancer therapeutics, it's some patients' last lifeline. And waiting for an Epic build, it's just not acceptable.
I feel like that was a very nice comment. Other questions for the crowd? Yes, sir. For the audience panel.
Yeah, I have a question related to, we always talk about in terms of IT implementations, we don't want to disrupt workflow. But we're talking about AI and we're already in agentic AI, and a multi-agent system in agentic AI is supposed to, if it works well, disrupt and create a new workflow that's more efficient. How do you guys look at that in terms of, maybe beyond today, but saying over the next few years, if we're really going to implement agentic AI and get the maximum out of it, how do we balance that with the staff who says you can't disrupt workflows?
Yeah, so let's start with you because you're on the front lines. I know we're running out of time, so can we do 30 seconds?
Yeah. The last
Yeah.
question, yeah.
Yeah, sorry.
Absolutely. No, it's an absolute real world logistical issue, right? Whether with the EHR implementation or things that are supposed to decrease administrative burden and increase flow, right? I say supposed to because we all go in well intentioned, but you never know how it's going to go. And adoption's so critical. And there's so much, why I brought up some of the other factors is there's so much demand, there's so much administrative burden that exists on practicing physicians and providers that any disruption is too much. So it's got to be well thought out. The implementation has to be laid out. The use case has to be laid out up front, even if you think best case scenario in terms of results.
Okay, any 20-second comment?
I'm going to compare it to Industrial Revolution I just spoke about this during my run this morning with a friend about, machinery that changed workflows, and we didn't know 100 years ago how it's going to play out. So what I'm thinking about is continuing measurement and continue, improvement cycles and adjustment. Otherwise, I'm done.
Yeah, sorry, just 2 quick comments and then we super have the hook. One is if you look at the PC revolution, in the initial days of the internet revolution, it took actually about 10 years for those technologies to actually lead to long-term productivity increases because it just takes us a long time to figure it out. And then I want to go back to your cancer piece. Just because we're in New York, I think it was about a year ago, maybe a year ago, April, when Brian was shot and executed. I think, and people were happy about it. Like, let's just be honest with you. Millions of Americans were happy when a healthcare leader got shot in the street who had a lovely family and everything I know was like a solid human being. Okay. And so I think we cannot underestimate where we sit as an industry in terms of stakeholder feelings about us, and we're worried about Judy and us and all this other stuff. And I just think it's important to keep an eye out that on the other side of that fence is a lot of unhappy people. Thanks.
Yeah, that was a great way to end this conversation.